Welcome, colleagues. It's a pleasure to be with you today. We're going to dive deep into a topic that is central to our practice, the anesthetic management for patients with severe cardiac disease. We're going to cover quite a bit of ground, from the nuances of chronic heart failure all the way to those acute life-and-death scenarios that we all prepare for in the operating room. So, here's our roadmap for this session. We'll start with the fundamentals of heart failure and its treatment ladder. Then, we'll get practical with some clinical cases to explore the different cardiomyopathies. From there, we'll tackle the very unique challenges of heart transplant and adult congenital heart disease. After that, a look at anesthesia for arrhythmia surgery. And we'll finish up with two critical emergencies that demand our sharpest skills, cardiac tamponade and major cardiac trauma. All right, so let's begin with the fundamentals. Heart failure. It's this incredibly complex clinical syndrome, really defined by the heart's inability to keep up with the body's metabolic demands. It's a progressive disease, and truly understanding its classification is key, because it tells the story of what our patients have been through long before they ever arrive in our OR. Now, this is really interesting because we use two completely different but complementary systems to classify these patients. On the left, you've got the ACC/AHA stages. Think of this as the story of the disease. It's about the objective structural progression. Stage A, they're just high risk, no structural disease yet. By stage D, they're in refractory end-stage heart failure. The key here is that a patient only moves forward through these stages. They never go back. On the other hand, the NYHA class on the right, that's a snapshot. It tells us about the patient's symptoms and functional capacity right now. With good treatment, a patient can go from a class IV back to a class I. So one tells the lifelong story, the other tells us how they're feeling today. And this really illustrates the typical journey our patients take. It almost always begins with foundational medical management, the ACE inhibitors, the beta blockers, all aimed at slowing down the disease. But when that's not enough, we escalate. We start looking at surgical interventions for structural problems, maybe a CABG for ischemia or a mitral valve repair. Then we look at the electrical side. Does the patient need a CRT for synchrony or an ICD for sudden death protection? As the disease continues to advance, we climb higher up the ladder to mechanical circulatory support. And then, for a very select group, the final definitive treatment, a heart transplant. So, this is a crucial point for us and our surgical colleagues, especially when considering something like a mitral valve surgery for functional MR. Before we commit a patient to that operation, we have to look at these predictors of a poor outcome. If a patient comes in with these findings, a massively dilated left ventricle, a high sphericity index, meaning it's remodeled from a football shape to more of a basketball, it suggests that the ventricle itself may have passed a point of no return. Even if we perfectly fix that leaky valve, the muscle itself might be too far gone to recover. We could be putting them through a huge risk surgery for very little benefit. Okay, so building on that foundation of heart failure, let's get into some specific cases. We're going to look at the three primary types of cardiomyopathy. I think this approach really highlights how we need to tailor our anesthetic strategies because each of these is a completely different pathophysiologic entity. So our first case is a classic HOCM presentation. You see this history and you're immediately concerned. The core problem here is that asymmetrically thickened septum, which creates a dynamic obstruction in the left ventricular outflow tract, the LVOT. And those two things in the history, syncope and a family history of sudden death, those are huge red flags. It tells us this patient is at high risk and intervention is urgent. Now, the surgical approach here has really evolved. The older Morrow procedure, well, it just involved resecting a chunk of that subaortic muscle. But the modern extended myectomy is much more elegant because it addresses the fundamental pathophysiology. The surgeons realized the problem wasn't just the bulky septum. It was the systolic anterior motion of the mitral valve, what we all call SAM, where the leaflet gets literally sucked into the outflow tract. So by resecting a broader trough of muscle, they actually redirect blood flow away from the mitral valve, which resolves the SAM and eliminates the obstruction. It's a much smarter approach. Okay, so the surgeon has completed the myocotomy, and we're getting ready to come off bypass. Our job is definitely not over. This is where we, as anesthesiologists, play a critical role. How can we challenge this repair right here, right now, in the OR? How do we make sure that this obstruction is truly gone and isn't going to rear its ugly head when the patient is awake, maybe a little bit hypovolemic, or gets a surge of catecholamines? We do it with these specific provocative maneuvers, all while we have the TE probe in watching very closely. We can create a transient state that would worsen an obstruction. We can briefly drop their preload with some reverse Trendelenburg or a tiny bolus of nitroglycerin. Or we can give a little bit of an inotrope to increase contractility. Each of these actions is designed to unmask any significant obstruction that's still there. And if we see a residual gradient pop up, say over 50 millimeters of mercury with provocation, that might just prompt the surgeon to go back on bypass and resect a little more. All right, our next case represents a completely different problem, global pump failure. This is a patient with end-stage dilated cardiomyopathy. Her heart is big, it's weak, and she's dependent on inotropes just to perfuse her organs while lying in bed. This is what we'd call an Intermax Profile 3 patient. And the critical piece of information here is that due to other health issues, she is not a candidate for a transplant. This fact completely changes our goal. We are no longer bridging to a transplant, we're looking for a long-term solution. And this is where this concept of destination therapy comes in. It's a true paradigm shift in how we think about heart failure. We are not just trying to buy time until a donor heart becomes available. We are implanting a device, an LVAD, as the final therapy. This is it. And we're not just offering a survival benefit. We're offering a dramatic improvement in their quality of life for patients who have truly run out of all other options. And this number really tells the story of how impactful this technology is. An 80% one-year survival was unthinkable with medications alone in this sick patient population. I mean, their mortality rates can be over 75% within just a couple of years. The development of these durable, continuous flow LVADs has completely rewritten the prognosis for these patients. Okay, our final case here highlights a major diagnostic and management challenge. This is restrictive cardiomyopathy. The problem here isn't a weak heart, it's a stiff heart. The ventricles are non-compliant, and clinically, it can look a lot like constrictive pericarditis. This patient has profound right-sided failure signs. But the key is that in RCM, the myocardium itself is the problem. And in his case, the disease has progressed so far that he has irreversible biventricular failure. This is critical because it means a left ventricular assist device, an LVAD, simply won't be enough. The failing right ventricle would never be able to handle the increased blood flow coming back to it from the device. So, because both ventricles have failed, the only viable option for mechanical support was the total artificial heart. And this is about as dramatic as it gets in cardiac surgery. The patient's native ventricles are literally cut out, they're excised, and replaced with this pneumatic pump. It completely takes over the function of the heart. This stabilizes their hemodynamics, it allows their other organs to recover, and it gives the patient a chance to get stronger while they wait for a donor heart. It is the ultimate bridge to transplantation when both ventricles have given out. All right, let's pivot now to two highly specialized areas, managing the very unique physiology of the transplanted heart, and then the incredible complexities of adults with congenital heart disease, or ACHD. Both of these patient populations require us to fundamentally shift our standard anesthetic thinking. For the denervated transplanted heart, there are three things you absolutely have to burn into your brain. First, because we've cut the vagus nerve, it has lost its parasympathetic brake, so its intrinsic resting heart rate is high, usually somewhere between 90 and 110. Second, without those autonomic reflexes, it is exquisitely preload dependent. It lives and dies by the Frank-Starling mechanism. And third, and this is huge for us, it will only respond to direct-acting agents like epinephrine or isoproterenol. Your indirect agents, like ephedrine, that depend on norepinephrine release from nerve terminals, those nerve terminals are gone, so those drugs will have a blunted effect or no effect at all. Okay, here's a classic question. It's a great one for oral boards because it really tests your understanding. We just established that anticholinergics can't affect the heart rate of a denervated heart. So if a drug like glycopyrrolate isn't going to cause tachycardia, why on earth do we still give it with our reversal agents like neostigmine? And the answer is pretty simple. We are not treating the heart. We can't. We're giving it to manage the systemic, non-cardiac side effects of the acetylcholinesterase inhibitor. We're trying to prevent the profound bronchospasm, the crazy salivation, and the GI hypermotility that would otherwise happen. We are treating the entire patient, not just their denervated heart. And just a quick surgical note here that has major clinical implications for us. The shift away from the older biatrial technique to the modern bicaval anastomosis has been a real game changer By preserving the natural geometry of the atria, it's led to much better hemodynamics, far lower rates of atrial arrhythmias and AV valve regurgitation, and ultimately, it's improved survival. It also means you're much less likely to see that classic 2P wave ECG that we used to see all the time. Now, let's talk about our adult congenital heart disease patients. For them, this balance is absolutely everything, especially if they have an intracardiac shunt. Every single thing we do directly impacts the ratio of their pulmonary to systemic vascular resistance, that PVR to SVR ratio. And that, in turn, dictates the direction of blood flow through their shunt. For instance, if we increase their FiO2 or hyperventilate them, we'll drop their PVR and increase left to right shunting. But on the flip side, things we see all the time, hypoxia, hypercarbia, or even just a painful stimulus, will raise their PVR, and that can worsen a right to left shunt and make them cyanotic. And this is why, for any patient with a known or even a potential intracardiac shunt, we have to be absolutely paranoid about de-airing our intravenous lines. It's not just good practice, it is a critical safety measure. Even a tiny amount of air from a peripheral IV can bypass the lungs, shoot across that shunt, enter the systemic circulation, and cause a catastrophic paradoxical embolization to the brain or the coronary arteries. All right, shifting gears from plumbing to electricity, let's talk for a moment about anesthesia for arrhythmia surgery. We'll focus mainly on the surgical ablation for atrial fibrillation, a procedure many of us know as the Mays procedure, which is designed to interrupt those reentrant circuits that keep AFib going. You know, the choice of technique here really dictates our entire anesthetic plan. The classic Cox Mays is a big, open, on-pump, arrested heart operation. It allows for incredibly precise lesion sets and makes it easy to excise the left atrial appendage. But the trend is definitely toward minimally invasive, off-pump approaches. These use epicardial energy sources on a beating heart, which avoids bypass entirely. For us, that means managing potential hemodynamic instability when the surgeon is applying the probes, and it almost always requires single-lung ventilation to give them the exposure they need. We're now entering the realm of true, time-sensitive cardiac emergencies, starting with pericardial tamponade. You have to remember, this isn't a problem with the muscle or the valves or the electricity. This is a purely mechanical problem of the heart being squeezed from the outside. If you take nothing else away from this talk about tamponade, remember this simple mantra. It perfectly and completely encapsulates the entire anesthesia strategy for a patient who is hemodynamically compromised from tamponade. It addresses the 3 critical physiological problems that we absolutely must counteract. So let's break down exactly what this means for us at the head of the bed. This table really unpacks the physiology behind that mantra. First, we keep the tank full. We do this with aggressive fluid resuscitation to maintain filling pressures and overcome that external compression. Second, we keep the heart rate fast. With a fixed, tiny stroke volume, tachycardia is the only way that patient can maintain their cardiac output. And third, we keep the heart strong. We have to preserve its contractility. These patients are running on a massive endogenous sympathetic surge. Our anesthetic, which should use agents like ketamine, must not blunt that critical, life-saving compensatory response. All right, our final section. This covers what is arguably the ultimate test of an anesthesiologist's skill, managing acute cardiac and aortic trauma, where the decisions we make in seconds will absolutely determine the outcome. So, picture this. You have a patient with a blunt, traumatic aortic injury. This is essentially a contained rupture of the aorta. Before the surgeon gets proximal and distal control, we have one job and one job only: minimize the shear stress on that damaged aortic wall. We have to do everything in our power to prevent a contained leak from becoming a catastrophic, complete rupture. And we do that by tightly controlling their hemodynamics. This is our absolute ceiling for systolic blood pressure. We have to walk this incredibly fine line, keeping the pressure low enough to prevent rupture, but just high enough to perfuse the brain and the kidneys. This is almost always achieved with carefully titrated infusions of vasodilators, like nitroprusside or nitroglycerin. And at the same time, we have to aggressively control the heart rate. We have to reduce that dP by dt, the force of ejection against that injured aorta. A rate at or below 100 is our goal, and this is usually done with a short-acting beta blocker infusion like esmolol. Controlling both blood pressure and heart rate is absolutely non-negotiable. Now, penetrating cardiac trauma, this is controlled chaos. There is simply no time for doing things one after the other. Our actions have to happen at the exact same time as the surgical teams. We assume a full stomach and profound hypovolemia. As the surgeon is prepping and making that thoracotomy incision, we are simultaneously securing the airway, slamming in large bore IVs and an arterial line, and screaming for blood. The induction of anesthesia often happens at the very moment the chest is being opened, and if you have TEE available, it is absolutely invaluable for diagnosing tamponade, assessing function, and guiding your resuscitation. So I think if there's one crucial point to take away from our entire discussion today, it's this contrast. Managing an adult with complex congenital heart disease, that's like being an architect restoring an ancient city. You need meticulous planning, and you must understand the complex, altered anatomy and physiology. On the other hand, managing acute cardiac trauma is like being an engineer at a dam that is actively cracking and about to collapse. It demands immediate, decisive action, all based on a few clear, life-saving principles. And for those moments, just remember, fast, full, and strong.